Good morning, good morning, good morning. Yeah. Good morning, everyone. Again, I apologize for the medium, but under the circumstances, this is the way the class needs to be offered today. Many of you have related to me just how much you dislike Zoom, but rules are rules, so I have to follow them. If you read my email, I will get a PCR test this afternoon. Well, no, this morning. Hopefully I'll get results quickly and then we'll figure out what it is I can do or can't do or what have you. So there we are. Okay. If you have a question, please unmute yourself and say something, because using the chat doesn't always work. And my speaker's on, I can hear you just fine. So feel free to just unmute yourself and barge right in. Okay. So let's, first of all, did you all get the PowerPoint I sent to you? You did? Good. All right. Then make sure you have that ready. We will be referencing it today at some point in time. All right. So we were talking about atherosclerosis. The PowerPoint I sent to you is a more specific explanation of how atherosclerosis develops and the role of LDL in the genesis and pathology of atherosclerosis. So let's just go ahead and go to that PowerPoint right now, and let's take a look at it. Very good. So here is a blood vessel. So you have in this blood vessel the walls of the vessel here. And right here, you have the endothelial cells. This is meant to be LDL. Your walls are here. Beneath this, it's not drawn, but it will be drawn later, are smooth muscles. Those smooth muscles will help the vessel constrict or dilate. When you have turbulence, or if you have hypertension or diabetes, or also angiotensin II, these endothelial cells will tend to peel off their basement membrane. When they peel off this basement membrane, LDL can now swoop in underneath and take up residence underneath here. So in the next slide, we see exactly that has happened. Here's your LDL that's snuck underneath here. Here's your damaged endothelial cell. This happens relatively often. So the endothelial cells peel off, they reattach. They peel off, they reattach. They do this more often in areas of high turbulence. And they do this more often in vessels where you have high levels of inflammation. Hypertension, diabetes mellitus, certain types of autoimmune diseases, also certain types of infectious diseases. For example, syphilis or Lyme disease will damage the endothelium and increase the likelihood that the endothelium peels away. Whenever it peels away, LDL can come underneath it and bind to the extracellular matrix that the endothelial cell sits on. This extracellular matrix is sticky. The LDL can stick to it. When that happens, the endothelial cell now acts like a foot with a pebble in its shoe. It starts to increase its production of reactive oxygen species. So this cell is now going to make reactive oxygen species. So that means it starts to make things like superoxide radicals. And it also makes things like hydrogen peroxide. And other types of molecules. These are reactive oxygen species. These will lead to LDL oxidation. That's why the LDL here is in red, unlike the gray stuff up here. This is now oxidized. This cell also will now start to produce cytokines, chemokines and cytokines. So it makes something called macrophage chemotactic protein. Macrophage chemotactic protein. Macrophage chemotactic protein lays breadcrumbs for macrophages. Macrophages will now be attracted to this endothelial cell. It also makes interleukin 8. That's a pro-inflammatory molecule. Then it makes on its surface cell adhesion molecules so that the macrophage can attach to it. So it makes the vascular cell adhesion molecule 1, the intracellular cell adhesion molecule 1, P-selectin, and then a pro-inflammatory receptor called the toll-like receptor 2. So these are for cell adhesion. This is pro-inflammation. So we oxidize the LDL. We now make things that will summon macrophages and let the macrophages attach once they get there. Next, the macrophages come and they attach. They attach because of the VCAM and the ICAM and the P-selectin. The other thing these cell adhesion molecules do is they allow the macrophages to roll, flatten out, and then move in between these endothelial cells. They're essentially going to come into the area underneath these endothelial cells. And that's in response to these secreted chemokines and cell adhesion molecules made by the endothelial cells. The endothelial cells make that in response to the underlying LDL, which is oxidized. The macrophages will now, they move beneath the endothelium, they phagocytize the oxidized LDL. Macrophages, as it turns out, are loaded for bear when it comes to taking up LDL. They have multiple receptors, not just for native LDL, but some receptors can handle both oxidized and native LDL. And then some specialize on oxidized LDL. They now make something called a fatty streak. These cells that have taken up the oxidized LDL, they're transformed into foam cells. These foam cells underneath the endothelium, they form a so-called fatty streak. Fatty streaks by themselves are relatively innocuous. It's what the fatty streak can become that now starts to become concerning. So the foam cells and the overlying endothelial cells now start to secrete various types of growth factors. And so the foam cells secrete these 4 main growth factors: transforming growth factor beta, platelet-derived growth factor, fibroblast growth factor, and then heparin-binding epidermal growth factor. Now, the fact that you're seeing growth factor, growth factor, growth factor should tell you that these proteins bind to members of the receptor tyrosine kinase family. So these are rather profound signaling proteins. These are going to transform these smooth muscle cells underneath the endothelium. They will induce their proliferation and their migration. They will migrate up here. They'll surround the foam cell. And they'll form essentially a cap around this foam cell. These smooth muscle cells, some of them can take up LDL and become transformed into foam cells as well. That will increase the size of the lesion. This lesion now becomes an atheroma. Oh, that's hard to write with a mouse. There. Atheroma. These cells are now going to secrete collagen. So they'll surround this with collagen. That's in response to TGF-beta secretion by the foam cell. And now this forms a so-called fibrous cap. Fibrous cap. Now you can see what's happening to the lumen of the vessel. The lumen of the vessel starts to become occluded. And over time, the foam cell will start to degrade, and it will start to secrete matrix metalloproteases. These matrix metalloproteases okay, that's ugly, but you get the point. Matrix metalloproteases degrade the endothelial cells here, and these endothelial cells will disappear, leaving this collagen here. When that happens, the clotting system is exposed to bare collagen. They'll now clot, and the clot, the yellow here, is the clot that occludes the vessel. So that's a thrombus. This can break off. If it breaks off, it becomes known as an embolus. So a thrombus forms in place, but the thrombus can occlude the vessel. If this occurs in a coronary artery, then that causes a myocardial infarction. If the embolus breaks off and gets lodged in the pulmonary circulation, then it becomes known as a pulmonary embolism, which is abbreviated PE, which does not mean physical education. It means something much more dangerous. If the clot gets lodged in the vessels of the brain, that will cause a trans-ischemic attack. We otherwise know a trans-ischemic attack as a stroke. So this is really the end result of this process. If you're here, this is stable. However, this slow but steady secretion of the matrix metalloproteases will start to degrade this endothelial layer. If it can't regenerate in time, it's going to progress to this. And that rupture of the atheroma, that's what essentially will cause a heart attack. All right, so as we said, atherosclerosis, the precursor of it, is chronically high serum cholesterol levels in the form of LDL. High serum cholesterol has to translate to high LDL. LDL is the particle that causes atherosclerosis. If you have too much of it, you're at risk for atherosclerosis. So this picture essentially shows you in one picture what that last sequence of slides just showed you. So you have, as you can see, the LDL getting underneath, getting oxidized. The endothelial cells make these cytokines, interleukins, MCP1. Macrophages come, move in between, take it up, become foam cells. The other piece in here that I did not include is that this cholesterol can be effluxed by HDL. That's why HDL is a protective particle. HDL protects because it can get rid of some of that fluid. These growth factors here made by these cells, the TGF beta, FGF, heparin binding, EGF, platelet-derived growth factor, drive the proliferation and movement of these smooth muscle cells. They then make this extracellular matrix. If this gets stripped, collagen then is thrombogenic, you'll get a clot. And this shows the progression from the damage of the endothelium to the underlying LDL, macrophage, recruitment, attachment, transformation into foam cells, movement of the smooth muscle cells, the formation of the fibrous cap and the fibrofatty atheroma, its eventual erosion and formation of a clot. Make sure you know these stages and make sure you know the molecules involved in the progression of these stages. So how do we nip this in the bud? We nip this in the bud by lowering LDL levels. The drugs of choice are statins, by far. Statins are the most successful drug of choice for lowering serum LDL. Statins inhibit HMG-CoA reductase, but as a side effect, they also upregulate the LDL receptor. That's really important. You upregulate the LDL receptor, you increase LDL removal from serum, therefore you lower LDL in serum and you prevent production of LDL because you're lowering endogenous cholesterol synthesis. Lovastatin was the very first statin ever produced. It was produced by Merck Corporation when Roy Vagelos was president of Merck. I think it was about 4 to 5 years later, Merck produced simvastatin, which went by the trade name of Zocor. Others include pravastatin, trade name was Provocol, then fluvastatin, atorvastatin, which was trademarked under the name Lipitor. This is by far the most successful statin of this group. In fact, Lipitor, atorvastatin is easily probably the most successful drug ever designed in terms of sheer dollar amounts that it produced for the company. And then rosuvastatin, which is definitely the most powerful of the statins. The piece I want you to see is this piece right here. That piece looks like HMG-CoA. So all of your statins will have this piece up here that structurally resembles HMG-CoA. That's how it's going to inhibit HMG-CoA reductase. So statins are going to inhibit HMG-CoA reductase. They therefore induce the synthesis of LDL receptors because intracellular concentrations of cholesterol are low. That's going to promote greater uptake of LDL. And your low intracellular cholesterol decreases secretion of VLDL. So less VLDL produced, more LDL taken up as a result of less cholesterol being made inside cells. So statins are easily the most effective drug when it comes to the anti-hyperlipidemics, by far. Second drug in this group are the fibrates. Fibrates aren't used all that much. Fibrates tend to be used for people who have high triglycerides. They're very good at decreasing triglycerides. Fibrates essentially are going to attack the problem they're going to stimulate this molecule called PPAR alpha. PPAR alpha, when it binds to certain fatty acids, stimulates the genes involved with fatty acid degradation. And it tends to prevent fatty acid synthesis and the synthesis of new fats. That's why it does such a good job at decreasing fat synthesis. So fibrates upregulate PPAR alpha. They decrease triglyceride synthesis. In doing that, they're going to increase HDL, because HDL, its components, the expression of those genes involved with HDL synthesis are controlled by PPAR alpha. They will therefore drop LDL, but not nearly as much as statins. And of the fibrates, really only one of them has been clinically shown to decrease serum cholesterol. And we'll get to that when we get to the next section. So they're not used really all that much. Here the fibrates all end in fibrate or fibrosol, gem fibrosol, clofibrate, phenofibrate. This is the one, gemfibrozil, that's been clinically shown to decrease the risk of heart attacks and things like that. So it's the only one really that the FDA has said is worth using. Gemfibrozil. The others, not really used that much. So they decrease triglycerides. They'll decrease LDL, but not all that much. They'll increase HDL, typically. Again, they're used mainly for hypertriglyceridemia, people with high triglycerides. Niacin is a drug that's used as well. Niacin is going to increase HDL synthesis, so it increases serum HDL. It has a modest, if any, effect on LDL. Niacin, if you take it, you have to take a ton of it. You have to take 1 gram a day. It's not terribly well tolerated by some people. You can get a so-called niacin flush, where your skin turns ripe red hot. If you take a baby aspirin half an hour before you take the niacin, you can prevent that. There are a lot of over-the-counter products that have niacin in them. And those over-the-counter products have been linked to liver damage. So if you take niacin, make sure you take prescription niacin. That's FDA approved. Niacin was combined with statins. Clinical studies have shown there's no benefit to including niacin. So the niacin statin combinations are not approved anymore by the FDA. Estrogens also have a very positive effect on HDL and also on lowering LDL. They do this mainly by decreasing HDL catabolism. Estrogens also tend to increase the synthesis of the LDL receptor. Estrogens do this because estrogens themselves are steroids. They need cholesterol, rather, the tissues that make estrogens need cholesterol. So estrogens induce those receptors that will lead to the binding and sequestration of more cholesterol. So estrogens are protective against atherosclerosis. Now, the downside of this is that some women after menopause think that they still have the protection of estrogen, when in fact they don't. And many physicians tend to ignore the risk of heart disease in women because of this. And now heart disease has become a major issue among postmenopausal women. Because of that, there's a need for more, let me rephrase that, for postmenopausal women to pay closer attention to a diet and exercise regimen as they get into those postmenopausal years. Because after menopause, you lose that cardioprotection of estrogens. All right, let me pause there. See if there were any questions about any of that. Go ahead and unmute yourself and ask your questions, because I'll be able to hear you. No questions?
What was the link between estrogen and HDL again?
HDL tends to prevent catabolism of HDL. So your rates of HDL production go up slightly, but your HDL has a much longer half-life in women. The other thing that raises HDL is exercise. However, the amount that it raises HDL varies from person to person, but exercise, consistent exercise, moderate, especially moderate to light exercise, are documented to raise HDL. Will they raise it a lot? No, but they'll raise it significantly enough to where your lipid panels will show a difference. Okay, let's have a look at the clinical uses of these drugs. So on page 62 of your handouts, there's a picture of all the different structures of the statins. And then starting on page 63, there's a table of the different types of drugs and their effects. I'll make reference to that table. So if you could have that at the ready, that will help us as we move on. Okay, so cholesterol, as you can see, does this little Texas two-step, if you will, from enterocytes to chylomicrons to the liver to VLDL to IDL to LDL to maybe back to the liver, maybe back to scavenger cells to HDL, back to the liver to bile salts, and out it goes. So hyperlipidemia or hypercholesterolemia usually involves elevation of your triglycerides, your lipids in general, or cholesterol. When cholesterol is measured, whole cholesterol is measured, and then that cholesterol is broken into free cholesterol, LDL cholesterol, HDL cholesterol, and LDL cholesterol. If your total cholesterol is above 200, you have hypercholesterolemia. If your LDL, depending on your age, is above 120, you'll be diagnosed with hypercholesterolemia. Your doctor usually won't do a lot about it until you get to above 50. If your triglycerides are increased, usually the number is 200. So between 50, if it's above 150, that's high. And if it's above 200, that's really high. You have hypertriglyceridemia. So elevation of any of these groups will justify a diagnosis of hyperlipidemia. There are several things that can cause hyperlipidemias. Obesity and overweight is definitely one of the biggest. So can physical inactivity, particularly if you link physical inactivity with a poor diet. Although physical inactivity, even with a reasonable diet, can essentially link you to hypertriglyceridemia, hyperlipidemia. My daughter, Rachel, went to school with a person who's actually writing programs now for video games. And her friend is a gamer herself. Gamers, because they spend a lot of time sitting, are at risk for hyperlipidemia. They're kind of one of the new groups that are being treated for hyperlipidemia. Cigarette smoking is another biggie. So is excess alcohol intake. Alcohol intake impairs the uptake of LDL by the liver because the liver is too busy dealing with alcohol. High carbohydrate intake, if you get more than 60% of your calories from carbs. Stress, of course, as well. Pregnancy in some cases can increase LDL, and then so can certain diseases, kidney diseases, diabetes, and then so can certain drugs. So steroids, corticosteroids, prednisones, things like that. Oral contraceptives can raise LDL. Certain anti-HIV proteases can raise LDLs. Not all of them, but most of them. And then various types of synthetic estrogens that are used for anti-cancer treatments can also raise LDLs. And then over on the right side of the panel here, you have a variety of conditions that can also raise serum LDL. I won't read those to you. You can read for yourself. The biggie I would add would be hypothyroidism. That can decrease LDL catabolism and raise LDL levels. So when you go to the doctor, you get your blood drawn, the doctor ticks that box on your sheet that says lipid panel. The technician will take the serum and will subject it to a kit. That kit will measure total cholesterol. It will also extract from that serum, that cholesterol fraction, the HDL, and then the LDL will be calculated as a fraction essentially of the whole cholesterol minus the free cholesterol. And that whole calculation gives you total cholesterol broken down into free LDL cholesterol and HDL. And then triglycerides are also calculated based on the fraction of molecules that are subject to degradation by lipases. And that gives you a nice quantitative number as well. So triglycerides, as we said, are 3 fatty acids, esterified to a glycerol. There's your ester bond right there, 3 of them. So this is a fat, it's a triglyceride, trifatty acid glyceride, triglyceride. Cholesterol comes from what we make and from what we eat. That's why lifestyle changes are usually the first thing that you do when it comes to controlling cholesterol. That means a decreased intake of saturated fat from animal products, decreased intake of sweets, greater intake of plant-based material, greater intake of polyunsaturated fatty acids, and also increased physical activity. So here's the panel on these. If your LDL is above 130 milligrams per deciliter, that's your borderline high. That's kind of what you have to play with. When you get older, if you're in borderline high, you're just considered high. In fact, my doctor wants mine below 100. Several other doctors have told me he's being ridiculous, but that's what my doctor says. If you're in this range here, yeah, you're really high. So essentially, you're in this range. The doctor recommends lifestyle changes. If you're above that, you need to be treated. HDL, you need to be above 40. If you're below 40, the HDL needs to be up. Triglycerides above 150 is high. If you're below 200, you're in that kind of borderline region. If you're above 200, you're high. If you're above 500, you're very high. Those are kind of the magic numbers. So hyperlipidemia increases your risk of myocardial infarction, increases your risk of stroke. So there are non-pharmacological ways of addressing hyperlipidemia, so-called therapeutic lifestyle changes. And there's 4 steps. With step 1, essentially, you recommend a simple set of dietary changes where the patient is to decrease their meat intake. So let's say they have, let's say they have steak 3 times a week and they have salami on their sandwich for lunch. You have them decrease the salami intake. So you decrease meat intake to once a day. And now you have them modify meat intake to more chicken and fish. So red meat to maybe once a week, if that. Also, encourage them to have leaner cuts of meat. Maybe something like maybe lamb or something like that that tends to be higher quality. Decrease intake of pork as well, which tends to be a little more marbled. Although American pork in the last 5 years has really increased in quality. So you're going to have them decrease the amount of meat they take in. You'll have them increase the amount of vegetables they take in. Step 2, you're going to have them increase physical activity. Taking walks, maybe going for runs. You'll now have them increase their levels of fruits and vegetables, decrease levels of meats. And that's basically each step. You're increasing levels of fruits and vegetables, things that are known to decrease LDL in the diet, like garlic, leafy greens, peppers, decreasing intake of meat, increasing amount of physical activity. You just step them through this. So with step 1, you might not recommend any physical activity. With step 2, you might say 10 minutes a day. Step 3, let's go to half an hour, either a day or at least 3 times a week. Step 4, maybe 30-minute walk 5 times a week. If you get to this range, things still aren't where they need to be, now you're going to recommend a drug. Now, if you get a patient who's already doing all this and they're still high and you haven't really needed to step them through there, then essentially you just skip go, collect $200 and recommend a drug right away. Also, in their lipid panel, if their triglycerides are high and their other, if their triglycerides are low, everything else is kind of high, that tells you it's probably not their diet, because triglycerides are very sensitive to diet. And have them just consider things that might raise triglycerides. For example, I did a little survey once of M&Ms that students eat from the Natural Sciences office. Students actually lose track of handfuls of M&Ms that they eat. One handful of M&Ms is one thing, but throughout the day, you'll actually be having 3, 4, 5 handfuls of M&Ms. People actually vastly underestimate the amount of sweets that they eat. Best way to do that is have them keep a food journal. Keep a food journal, you get a much better idea of your food and sweet intake. And so here are your goals. And these are actually found on page 66 of your materials. And then page 68 as well. This table, in fact, is from page 68 of your notes. Those are from the NCEP treatment goals of 2004. They've changed very little, except that if someone is a diabetic, you're essentially going to add about 20 to their LDL. You're also going to want their LDL to be low, very, very low, like below 100 consistently. Some people have an inherited condition called familial hypercholesterolemia. And familial hypercholesterolemia is due to mutations in the genes that encode components of the LDL reuptake system. Could be the LDL receptor, could be adaptins, could be whatever. But these people need drug treatment. They will start to show the effects of atherosclerosis very early in life. And so they need to be treated very early in life. There are good genetic tests for these diseases. Also, they tend to run in families. So if you suspect these, just order the genetic tests and start treating them aggressively soon. Okay, so I don't want to reread you the riot act on this, but remember that the linchpin for cholesterol biosynthesis is HMG-CoA reductase. Statins inhibit that step. Insulin upregulates that step. That's why increased glucose intake will increase your cholesterol synthesis and VLDL output by the liver. Glucagon will inhibit HMG-CoA reductase. Statins will also decrease the LDL output and they increase LDL uptake. So statins, as we said, they have a lot of knockoff effects that people really didn't consider. Inside blood vessels, statins have an anti-inflammatory effect. They tend to increase insulin sensitivity. They tend to decrease platelet aggregation. In blood vessels, they decrease proteinuria, at least in diabetics. They have a whole lot of benefits. The other beauty of statins is that there are many different types of statins. If one statin doesn't work, you can, or if the patient doesn't tolerate one statin, you can switch them to another statin very quickly, very easily. And they'll often tolerate that other statin. Also, statins tend to be active at many different concentrations. So if one concentration doesn't work, you just up the concentration. So they're very flexible in doses too. This is shown on page 68 of your notes, and it simply details the intracellular effects of statins. Once again, you're decreasing HMG-CoA reductase. By reducing HMG-CoA reductase, You trigger genes that encode the LDL receptor. Greater amounts of the LDL receptor cause increased LDL clearance from the serum, and you therefore decrease VLDL synthesis. Notice all these drugs end in vastatin. Vastatin. So atorvastatin, fluvastatin, lovastatin, pravastatin, pitavastatin, simvastatin, rosuvastatin. Pitavastatin is the newest of this group. It comes in a suspension and also in a pill. Statins tend to be taken orally. Lovastatin comes in an extended release form, as does fluvastatin. These are oral drugs. On the average, statins are very well tolerated. Millions of prescriptions have been written for statin. Their drug adverse effect profile is very, very good. Most people who take statins have few to no side effects. Gastrointestinal disturbances are usually transient. If you can't tolerate a statin, usually you can switch to another statin and usually tolerate that one. Hepatic dysfunction is also rare. Also, that's usually fixed by switching to another statin. CNS effects. Some people get depressed on statins. Again, by switching to a different statin, you tend to mitigate that effect, but that's also rare. How rare is rare? 0.1%. Hepatic dysfunction, maybe 1%, if that. It's probably lower than 1%. The big side effect with statins will be muscle pain, usually in the legs. Joint pain's been reported, but it's usually muscle pain in the legs. So myositis, the severe side effect you need to worry about is rhabdomyolysis. In this case, the muscle starts to break down. You get big macromolecular assemblages of muscle protein in the blood. Those get stuck in the kidney and they start to damage the kidney. If you have a dark brown urine, that's usually a sign with lots of muscle pain. That's a sign of rhabdomyolysis. Another sign of rhabdomyolysis is the enzyme creatine kinase in the blood. Large levels of creatine kinase in the blood indicate rhabdomyolysis. If you start to get rhabdomyolysis, you need to get off the drug immediately. So statins raise HDL slightly. They lower LDL significantly. They've been shown in several large, well-controlled clinical studies to decrease the risk and incidence of cardiovascular events. You get lowered congestive heart disease, lower heart attacks, lower incidence of stroke. They're very widely used because they're well tolerated and they work. Those are your drugs of choice. You can see on the table on page 63. The big thing you need to worry about is drug interactions. There are a couple of statins that are degraded by CYP3A4. So that's mainly simvastatin in particular. Simvastatin is a 3A4 inhibitor. Atorvastatin is not. Others are cleared by phase 2 reactions. So you don't have to worry about the cytochrome P450 interactions. And I say that right here. So lovastatin, simvastatin are 3A4 inhibitors. Atorvastatin is not. Atorvastatin, simvastatin, lovastatin are 3A4 substrates. So if you use them with 3A4 inhibitors, like erythromycin, grapefruit juice, so on and so forth, cyclosporin, ketoconazole, blah, 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 you'll increase the concentration of those drugs, increase the risk of rhabdomyolysis. They can also interact with warfarin. And they also interact with gemfibrozole, so you don't use them as gemfibrozole. And you don't use them with bile acid sequestrants, which we're going to talk about next. Very quickly, because we're running out of time. So bile acid sequestrants grab cholesterol, grab bile salts in the intestine, and prevent their reabsorption. They cause their secretion, their excretion in fecal material. You use them in people who cannot tolerate statins. These drugs are not absorbed systemically. Because of that, they have very few systemic side effects. So they grab the cholesterol, grab the bile acids, prevent their reabsorption. They go out with the wash, so to speak. That decreases your cholesterol in general. So you increase clearance of LDL because you have to replace those bile salts. The side effects with these are GI related because they work in the GI tract. Constipation is a rather frequent complaint. However, using laxatives can abate that, as the cartoon over here will indicate. Gallstones have been seen in some people, but these drugs are typically not intended to be used long-term. If you use them long-term, then they're a problem. Cholesterol is the drug that's best tolerated. And these are the three drugs here: cholestyramine, cholestipol, and cholesterol. They may raise triglycerides, therefore you don't use them in people with really high triglycerides. And some special considerations. That's all we have time for today. So I will let you know about my COVID test, which I'll get this morning. And that's going to determine my future, essentially, whether I have to be on quarantine for 10 days or whether I can come back. So thank you all for your patience. I will hang out here and entertain any questions you might have. Other than that, please have a very blessed day.
Dr. Baranovich, are we going to have a quiz this week?
If you do, it'll be online.
Okay. All right. Thank you.
Oh, yeah, and don't forget the online quiz, guys. Don't forget the online quiz. It's due tonight before midnight.
Thank you.
You're very welcome. Cade, your last exam didn't go so well. Is there anything I can do, Cade, to help you learn better?